All right, everyone, we'll go ahead and get started over here. Don't forget, if your camera is on, you'll be paid for this staff meeting. But make sure you keep it on for the majority of the meeting, not 1 minute in and then for the last minute. We have a lot of things to go over on our agenda here. So we'll get started with our care commitment, which Mimi will be the one talking about that. Mimi, whenever you're ready.
Yay.
Also, Saul, I do not see your screen. There we go.
Hi, everybody. So, our care commitment today is taking care of Methodists. Um, so, can you hear me?
Yeah.
Oh, okay. So, like I said, our care commitment today is taking care of Methodists. Um, we know that we understand that Methodist is more than just a workplace, it's a community and a legacy. Every interaction have whether with patients, family, colleagues, or visitors, shape how others perceive Methodists. And one thing I like about it is that the ownership, continual improvement, elevating others' experiences, professionalism. Let me just say a little bit. Let me just give a little example about the professionalism. That's one thing that I have seen. What Methodism, I will use A5 as an example. When it comes to professionalism, we actually exhibit that. Every one of us. We make sure we represent Methodism in every way possible. The ethical practice, you talk about the teamwork, you talk about the attitude that we all bring to the job, and the culture and public as a whole. And I have a little quote that says, I want you to remember, right, that when it comes to excellence, it's not accidental, it's actually intentional. All right. In summary, taking care of Methodists means protecting the missions of Methodists, strengthening the culture, improving the systems, elevating patients and colleague experiences, leaving the organization better than you found it when you walk in. And I just want us all to reflect on accountability, stewardship, and the pride in where we serve. That's what I have for today.
Very good, Mimi. I like that quote. Thank you for speaking and presenting on the care commitment. Very good. On our kudos here, it was really neat reading a lot of these different kudos, what patients and their families wrote, and a lot of them are very specific on how people went above and beyond or how they appreciate the care that they receive for their loved one or for themselves. For example, with Rachel Longo having the heart of an angel, her picking the correct job. She has a laugh that will make you smile no matter what. And Rachel received about 10 of these uh, kudos over the past month. So great job with that, Rachel. Or even with Curtis being very caring and compassionate with the dad of the family member. Having him open his eyes, not just physically, but emotionally, which meant more to the family than words can express. And you reminded him that his life truly matters and that he still has so many moments to cherish with his grandbabies and loved ones. So that was really, really neat, really nice hearing those type of things. And then we go on hearing a few other things also with Nadia and her patient also, showing a lot of care, empathy, expertise in a very difficult time and life event for them, having just amazing bedside manner. Or even with Ashley S., taking care of the patient before their procedure. She was all over the schedule for the fasting and fluid restrictions and using the whiteboard to communicate and write everything down as far as their restrictions, their schedule, the name of the different doctors, so that they're really appreciative about that and just keeping them up to date on what's happening with their plan of care. So Jackie and Rachel saying this team's full of angels and they're getting better because of their help. So thank you everyone, not just on these slides, but everyone else who does a really great job on making sure that we provide the best care for our patients. We had a lot of February birthdays and anniversaries. Valentine's baby, Anna, two that share the same birthday, Bianca Patrice, Yazin McKenna, Christina Sean, happy birthday here for the month of February. A lot of anniversaries too, from 4 to 12 years. Sean Nung, Christina Like, Ashley Hong, Shauna Rhodey's on Friday. So happy birthday and happy anniversary to all you guys. Next up, we have Sarah with our education.
Hello. All right. So, you know how we started the Code Blue Unplug for FY 2025? And you can see the difference that we have made. So, if you look at the scores from 2024, our ROS went from 72 to 76, and American Heart Association national average is 71%. Survival to discharge, we went from 18 to 28%, and AHA's national average is 25%. So, doing these Code Blues mock drills really did help out, gave us great patient outcomes. You go to the next slide. So we're doing the Code Blue Unplug again. You can go ahead and register into Methodist University ahead of time if you like. There's 2 dates scheduled for A5. So you got April 2nd and July 14th. And your A5 co-champions are Johnny and Ahenemy. So thank y'all for being with Code Blue, your champions. Next slide. And then February 9th, you should have noticed an update with the AVS. You can now choose different languages upon discharge, and you can get more information in the Epic Hub. There'll be more upgrades in April. And if y'all remember Fawn Rojas, she'll be in the hospital the last week of March making rounds to talk to everyone about exciting updates that's coming up in April with Epic. Next slide. And then Care with Dignity, this is a free webinar plus 1 CE from Walden University. It's via Zoom, of course, and you can sign up for the webinar. If you don't make it to the time that it's scheduled, that's fine. As long as you sign up for it, you can watch it live anytime. So it's a great CE there for you for free. Next slide. And then our February free CEs from health.edu are available, and human trafficking is something new that they put on there. And as y'all know, for Texas Board of Nursing, this is a requirement yearly. So here's a free human trafficking training course that you can do and earn your CE. And next slide. And then dysarthria exam started this month. So if y'all want to knock that out of the way and get it done, you can go ahead and do that. And you have to August 30th to do the non-proctor exam. And then after that, it's proctored. Next slide. And then finally got our trauma education all situated. So it's already loaded up into your Methodist University. When you open it up, you'll get this screen that you see down below. You're going to get an attestation form, and also it's going to tell you a list of options that you can do. If you do anything that's outside of Methodist University, it shows you how you can upload those documents into Workday. And again, all you need is 4 hours. All that information is included on the module. Next slide. And then Methodist Dallas College will be coming, let's see, to Mansfield on March 12th. And they will be discussing anyone that wants to become a nurse. They'll do the associate degree nursing. And then if you have your associate degree nursing license, you want to get your BSN, they'll be talking about that afterwards. Next slide. And then if y'all know anyone that wants to be a certified patient care technician who has zero experience. They want to get their foot in the door. The program starts March 23rd, although we don't have any positions open in Mansfield, but other facilities do. Just spread the word because, we like to grow our own. Next slide. And finally, this has been a long work in progress. So for those of y'all who are certified PCTs, your certificate is good for 2 years and you have to renew it. So now you can get reimbursed that $200 renewal fee. So if you're due for renewal and you've paid, you can get reimbursed back that money by going to the Pulse page and go under the nursing hub and certificate information, and you want to be sure to click on the MHS guidelines for PCT certificate reimbursements. And next slide. And May's coming up here pretty soon for our Nurses Week. And so our Nurse Excellent nomination is up. Flyers are posted around the hospital. Also, we have it on our website. And or you can scan this QR code here on your screen and vote for Rookie of the Year, Nurse of the Year, things like that. And then we have our certified PCT and nursing headshots. That's coming up on February 20th. If you'd like to get your headshot done, if it wasn't done yet, from 7:30 to 9 a.m. Next slide. Then here's some cap level and volunteer hours. I know one of them short notice is on the 22nd. That just popped up on the email not too long ago. And then here's some other dates here. Remember, you need a total of 8 hours of health related volunteer hours to earn that 1 point. Next slide. Here's another cap leveling EVP project idea for cost savings. To the right is a carpio jet. That's what you use for your morphine or Dilaudid that comes in those little glass tubing. And the benefits of using that, it eliminates the time needed to draw up the medication. It's a closed system, so it reduces contamination risk. It also decreases the risk of needle sticks injuries, and it increases nursing workflow efficiency. Plus, it's reusable and it saves money. So if you grab a blunt needle and a 3cc syringe and you draw it out from that vial, is 12 cents versus 0.00016. I mean, this carpio jet costs less than a penny. And you can wipe it down with the Saline wipe and keep using it over and over and over again. We just don't utilize it very much at all, and I think we should. But once you're done using the medication, it's going to have to go in the sharps because the medication does have a needle built inside of it. And if anyone's interested in that, just let Sol know, let me know. And I'm waiting for our rep from Pfizer to give me samples of fake medication, sterile water, so that way I can practice using the carpio jet. So that way y'all don't practice with real medicine and then y'all break it or spill it and then you have to waste the narcotic. So anyways, just an idea. Next slide, or that's probably it. Yep, that's it.
All right, thank you, Sarah. And
You're
when
welcome.
when Sarah mentioned the Code Blue data, I think about a quarter ago, several months ago, A5, I think, had 4 Code Blues during those 3 months, and we achieved ROSC on 3 of those. So we had a really high percentage of doing that, which goes to show the teamwork, the attention you guys give, understanding your role, what you have to do, doing early chest compressions. So achieving ROSC and a higher percentage just shows the great work that you guys do. So great job with that. And the Code Blue class, many of you attended it last year. This is for anybody that's BLS certified. 2 classes, one in April, one in July, 7:30 a.m. to 11:30 a.m. You do get paid for those 4 hours, and we'll be sending out a sign-up sheet of when you can sign up for that also. Next up, Shauna with our Rise Skill of the Month.
Hey everybody, I'm gonna make it kind of quick. Sorry, just 1 second. This month's RISE universal skill is be sure. We want to make sure we see and identify issues, understand what causes them, have a response to that, and then evaluate the response. We want to make sure we use critical thinking skills to find those issues to prevent errors. To see the issue, we want to make sure we know what causes or contributes to the issue and know the full situation so we can try to understand it. For understanding the cause, we want to make sure we know what happens versus what we want to happen and find the why in the situation. For responding to the cause, how does this affect us? How can we make changes to alter the outcomes? And to evaluate our responses, we want to reflect on the changes that we've made and continue to think and improve as we go on and always have that continuing education. Thank you, guys.
Thank you, Shauna. Always presenting a very nice skill of the month. I like the color scheme also. Next up, some important information from Kayla with CARC updates and leveling.
Hey everybody, I just wanted to touch up on some CARC updates. If you're in UBC, you've heard me talk about them, but if not, I wanted to address it with everybody else. So this year, there are some really big changes to our leveling binders in the book. One of the biggest changes that a lot of people are going to be affected by is that with written recognition, normally years prior, you could get up to 3 points with the written recognitions, with 3 like grade awards or whatever being 1 point. This year, they've changed that to only 1 point max. So you can get 3 written recognitions for 1 point, and that's it. Another change is that for skill validators, before you had to get 10 signatures on 1 skill in order for it to equal a point. Now they've changed it to where you can split it up between skills. So say you have Foley's and blood and you get 5 on each, that's 1 point. But if you get 10 on Foley, that's still 1 point as well. You can just split up those signatures instead for 1 point. The next change is that if you are in a leadership position in a committee, prior you had to have like 75% of the minutes, which was a lot. Now they've changed it to where you only had to have 2 of the meeting minutes, just like if you were just a regular member. And then I also wanted to touch base on bulletin boards because we've been getting a lot of questions about this. So for a bulletin board point, you have to show that you were changing and updating a bulletin board monthly for a minimum of 6 months. It is possible. We do have 1 bulletin board that can be used, I believe. I do know some people have asked about it. I just want to point out that if you do this, you have to change the whole board every single month. Make sure you take pictures and make sure that your board is labeled with the month that you're teaching on. And it has to be 6 months. However, an easier way to earn a point would be with UBC, we're doing Education of the Month. I don't know if y'all have seen, but in the med rooms, there is the bulletin board there, and we've been updating that monthly with Education of the Month. And if you volunteer for that and you take over that month, that can be a point as well. It would just be a point that falls under education instead of under bulletin board. So that's just something to think about. I do know that if you are still thinking about doing a bulletin board, I think Saul had some ideas for some that might work out as well. Does anyone have any questions on that? Okay, I think that's it, Saul.
Thank you, Kayla. And if you are looking for some points, there's a couple projects that we do need help on, which is blood culture, C. diff, responsiveness of staff, plan of care, and the cost savings that Sarah mentioned earlier. And Crystal will talk more about those cultures that it'll be a new process or something new that we're adding to it. You want to start early. It's only less than 6 months away of what you have to do. And make sure that if you need help with something, you can ask Kayla. If you don't know what project you want to do and you're looking for something, ask myself, ask Crystal. So you're not waiting till the very last minute trying to do something or trying to find ways to get points. But there's a lot of ways to get points out there. If you have, again, questions, let us know. We can direct you in the right place. Next up, Crystal has a lot of great information on her updates.
Hi, y'all. Just remember that anything that I discuss with y'all is all out of love, and that, I just hold A5 to a higher standard, and that there are just expectations for the unit. So please just have our listening ears on. The first thing I want to talk about specifically are our lines. So I have noticed here recently, just because a lot of what I do for the floor is quality. And so I have noticed here recently with our lines that they are no longer being labeled. I know that we were out printer paper for a while for the Omnicels, but we still have all of those, Monday, Tuesday, Wednesday labels that we could use. But I have noticed a whole lot of lines that are no longer, we're not labeling them anymore. So please make sure that you are labeling every single line when we're hanging them in the rooms and changing them accordingly. We have made obviously our CHG bathing priority, so please continue to have those done by noon or midnight for our lines. Policy states that we just give one CHG bath a day, but A5 for the longest time has been doing twice a day. And so just have that discussion with your patients. But every patient every day needs a bath and a linen change. Okay, so this is goals for our unit, that our patients and that those that we serve, especially while they're sick and having all these other things happening with them, that we are keeping them human, that we're brushing teeth, that we are doing those normal activities of daily living that you do yourself, right? We get up, we brush our teeth, we wash our face, we bathe. Hopefully, we all bathe every single day. Just be mindful that these people need to be treated the same. So we need to be coordinating with each other, with our PCTs. If you're the nurse, coordinate with them on how you want baths to look, or maybe they already have a plan on how that needs to look for them for that shift. But this needs to be a daily expectation. Those patients with cultures, nurses, that if you have a line and the physician is ordering a culture, so urine, blood, or even C. diff, these are huge areas that our hospital is going to be a major focus on this year. And so just because it does seem like sometimes some of these cultures have just been ordered willy-nilly, and we're collecting them willy-nilly without kind of like looking through the chart. Is this appropriate? Does this need to happen? Those kind of things. And so Nora has held a couple of sessions with your charge nurses and explaining to them the different algorithms now for when we have a culture for urine, when we have a culture to be drawn for blood, those kind of things, that your charge nurse, I actually printed it off for them today because I attended it as well. I wanted to know specifically what she was giving to them. Just the different algorithm on isn't appropriate for us to collect. So if I did have our two cotties and, maybe those could have been prevented. We're not saying to not collect, but we are saying to follow a process and just making sure that we're doing what's best for the patient. Okay. If it doesn't change their plan of care, do we really need to have that culture drawn? Okay. If your patient's coming in with diarrhea and they're having loose stool on admission, we should be collecting that on admission, right? We're not waiting 72 hours and being like, hey, doc, by the way, they have had more loose stool and now we want to collect, and now it's positive for C. diff, which is hospital acquired. Okay, we want to get away from all of that. We want to do what's best for the patient, but we also, don't want to be ordering cultures just because. And so there's a new process for that. We're actually going to come up with, just like we've been talking about it too, like if you have a culture, go to your charge nurse and you guys go through that reference sheet. That will still remain. We'll put up a bunch of signage around the unit as well, just to help remind you of that. and just the best steps to take whenever caring for your patients as well, who maybe have C. diff, those kind of things. And so you'll just notice a little bit of change with that. Or if you do have a culture, please come by, ask myself, or your charge nurses on what the next steps are going before you collect. Okay. The pictures here below you see are 2 photos that were taken by infection prevention. There's a quality person that is now assigned to our unit that will be looking over all of our lines, and asking our charges a bunch of different questions as well, pertaining to those lines. And so, very simple, even at huddle, your charges, you guys will notice that maybe they say, this line in 14, it's been in for, or this Foley that's been in for 4 days. Can we see about getting that out today? Have restarted avoiding trial, like just kind of like voicing it and just making sure that we're getting those lines out as soon as possible, those kind of things. But these Foleys here were taken by that infection prevention. And you can see that obviously there's major J loops here. Okay. So maybe those Foleys, that stat log, maybe it needs to be adjusted on that patient so there's no dependent loops. Maybe we need to hang that hook further down the bed so that there's no J loops on these patients. Shauna had a great example or process, like an intervention kind of thing that we can use these clips, these different clips that you can get at the dollar store or whatever. I don't know if they're curtain clips. I don't know what, but it's so we can hang them further on the bed, kind of like a little extension that we can get really cheap, that we can utilize around the unit, that we can clean. And so that way we can hang these Foleys, because I know that sometimes just how tall the patient is, all the things matter, right? On making sure that this is as straight as possible. But we did get caught red-handed with these 2 this day. So mindful of that. Next slide, please. Any questions about what we're doing with our lines, or any comments anybody wants to make with lines? Okay. So gloves. This is kind of a pet peeve of mine, but it's also a Joint Commission standard. Nobody should be in the hallways with gloves on. I don't know if you just came out of a room with dirty gloves. I don't know if you're about to just walk into a room, but if you're walking down the hallway and you're going to be going and touching other things and then walking into your patient's room, your gloves are dirty already. So now you're walking to your patient's room with dirty gloves. Plus, I don't know if you're in the hallway with dirty gloves, all the things. Please do not walk around the halls with gloves on, okay? The other thing I want to talk about with gloves too is something that I have done in my practice. And, you don't have to do this. Just a suggestion is anytime that I give hygiene care to a patient, if I know that I'm going to change them, I always put 2 gloves on. I put my regular normal size gloves on and then the size up from that, just because we've got a bowel movement, or even just, they've peed and I'm cleaning them. Just now I'm going to take my dirty glove off and now I have clean gloves on. So now I can touch their bed rails. Now I can touch their trays. But what I notice, which I know is normal practice, right, is we give hygiene care. Now we're touching the bed railings, and now, and you just have poo-poo hands. You literally have poo-poo hands and you're touching this patient's bed. And we're not wiping this patient's bed after we did that. We're adjusting the tray table and we've got poo-poo, pee-pee hands, and it's like, if you went pee or if you went poop, you're going to go wash your hands. You're not going to go, I don't know, eat dinner or grab a handful of popcorn. You're not going to go do that. But these people are in their room and like we're touching all their stuff with like dirty hands, right? And so I just want y'all to be mindful of that. And one of the changes that's going to be made with this quality and focusing on our lines is that patients are going to be, say they're going to be here for a long time. Say you have a patient that has a Foley, right? And, but they're here for a long time because maybe they're not going to go to rehab or wherever they're going to go. anytime soon. If they're going to be here for longer than 14 days, we're actually going to be moving patients to a different room, to a clean room on a new bed, so that that room can be terminally cleaned. So that was another change and a process improvement to see if it helps with the percentage of those patients that have these PICC lines that are in for a long term. Foley's the same thing, to decrease CAUTIs and CLABSIs. So that's to come. Just FYI, those patients with lines, if they're going to be in there for over 14 days, they're going to be moved to another room, and that room will be terminally cleaned. And so, but again, just to say that just be mindful that these are their room, and we don't want to be like dirtying their stuff. You know, we are helping them, but please just like be careful with the gloves. The other thing I want to talk about is after our patients have a bowel movement, we should be removing that trash from their room. Nobody wants to sit and smell their poop, right? All day long with the door closed. We also don't want our patients and their guests that come to walk into the room and they now just smelled that they had a bowel movement. You know, like this is their home while they are here, and we want to make sure that that their stay is clean, right? And that we're not leaving just soiled urine, nasty, like a lot of urine and bowel movement trash in there, and then trapping it in the room when we close the door, and now they just have to sit and smell it. Okay. We don't need to wait for EVS to do it. We are more than capable of doing it. And so that's just one thing that I wanted y'all to be aware of as well. The next thing I want to talk about is our nutrition room. So one thing that has been voiced is that this room gets trashed, and it gets trashed pretty quickly. And so please make sure that we are picking up after ourselves, and it's not just EVS or secretary's role to be cleaning this area. This room actually is a hot spot for Joint Commission. It's such an easy find for them to find something in this specific room, you know, of like crumbs in the drawers, the microwave has spaghetti all over the inside because nobody cleaned it out or whatever, expired, you know, juices, those kind of things. It's very easy for them to go find these things. And it's one of those rooms that, you know, we shouldn't have to be like rushing to like clean. Again, the unit should be Joint Commission ready at all times for just anybody, even just anybody to come up and to look through the hospital and be like, gosh, your hospital is so beautiful. It's always clean. You know, the hall that my mom was on was always so clean and picked up. So again, the nutrition room, we need to make sure that we're picking up after ourselves. Are there other units going into our nutrition room? Another thing that has been said is that a lot of our food or our Cokes and all the things get eaten rather quickly. Okay. It's ordered like weekly, twice a week, or however often it is, but then like the next day it's gone once it's been replenished. And so we are working with our secretaries to probably change that door code. And so right now we know that there is actually like a universal code through the hospital for the nutrition rooms. I don't know what it is. I didn't know that there was a universal code, but it's not 0072, you know? And so we probably will be changing that code. We will let you know what that is, and we will be removing the option to have it be universal just because, yeah, that's what it is, Curtis, 5150. And so who knew? But also make sure that that nutrition room, it is for patients only. We're not feeding the masses. We're not feeding families. We're not giving everybody all the Cokes. If you notice that your patient is having a lot of, maybe they're ordering or like asking for Coke all the time, or maybe they're asking for peanut butter crackers all the time, we need to ask them that if they want all these like extras, that they can order that with their trays. And so that way they have extra in their room anytime that they want that, just because we only get a limited supply. So figure out however you want to say that and suggest that to your patients, whatever is easiest for you. But whatever is ordered, it's limited in stock and it's for a whole entire unit for a lot of patients. So if they want to order anything extra, they can do that with their trays. And also if their family needs food or anything like that, then they can do that downstairs in the cafeteria during cafeteria hours. Okay. Any questions about anything I've talked about just yet? The next thing is for ambulation. This has been on Circle Up for a minute too. Another pet peeve of mine is that patients should not be immobile for over 24 hours. We do not need physical therapy or occupational therapy to assess our patients and how they move. Whenever Trisha was here, we had the mobility project and that was going well. And then obviously we didn't need that service line anymore for us and our patients. But if I'm here during day shift and you guys want to move your patient because maybe you're a little nervous or you're not sure on what to do, I do not mind moving people at all. I do not mind at all. These people, even if it's just to sit on the edge of the bed for a little core work, a little back, exercise, however they want to do, stretch those lungs for even like 3 minutes. If that's the max that they can do, at least you can report that to physical therapy. At least you can say, we tried to get up today. All that they could do was sit on the edge of the bed. So maybe you can do more, or this is all that I was able to do. This was all the patient was able to do. We couldn't stand. But we should be assessing our patients on their mobility and making sure that they are mobile during their stay. We do not want to debilitate our patients any more than what they've already came in with generalized weakness, however that might look. Their goal is to go home, and that should be our goal for our patients as well. Our goal is not to send them to rehab. Our goal is to send them home with as much strength as possible. So the other thing was to follow orders with patients with fractures. Sometimes these patients do come in and they have fallen and they might have a fracture. But if you have an order that your physician has given you to still be able to ambulate, you can ambulate your patient. Okay, give them pain medicine if they need it to get up and move. If they have a back brace ordered, put the back brace on them and move them. But please do not keep our patients stuck in the bed. That's just a no. Okay. Next page, please. This update is for stroke. For our stroke population, we know that we are moving to level 2 traumas, but we have been doing thrombectomies, that we are thrombectomy capable for our neuro population. And so Chris, our stroke coordinator, had a meeting last week, and one of the topics was non-complicated thrombectomies. And this was for our population that maybe they came in and their NIH was like at 14. They ended up with a thrombectomy. These patients actually might be transferred to us less than 24 hours post thrombectomy. Please don't let this scare you. These patients are the non-complicated ones. Like now, maybe their NIH is a 0. Maybe it's a 1 now. There's nothing special to their care besides the normal stroke orders. Okay. Definitely, we still need to be making sure that their neuro checks are done, all the same stroke workup for these people, all the same education, all the things. Okay. Your charge nurses will be making sure that these patients will have the routine orders. There's nothing else extra to come with them. And so I don't want you to be nervous whenever they do come if it's been less than 24 hours. Specifically with them. Okay. And it's few and far between. Apparently, maybe like there's not that many that there has been a need. And so that's why they wanted to discuss it and have voted that yes, we would do that. At discharge, I do just want to reiterate, because I've had a couple here recently come back to me. When you are discharging a patient, if Kayla's not discharging your patient, we still need to make sure that we are doing all the things. Okay. I know that whenever you don't do things, you become, not as skilled in them, but on our stroke population, our patients when they're discharging with new medication, there needs to be printed education for those new meds, okay? And then in the risk factors for our patients in the stroke population, especially those TIAs. We want to make sure that these people never ever come back with an actual true stroke. Okay. And so they need to be really educated on those risk factors that they might have. And anytime you talk to them about it, you need to please document it under education in your comments, their risk factors that you spoke to them about. That needs to be done every shift. That's not just one person, one time. I mean, we need to be really educating and talking to this population and protecting them and making sure that they don't ever have to come back with a true stroke. Okay. The next one is cleanliness of the unit in our patient rooms. I already kind of talked about this, but I will give an example. And, you know, Tanner's from B4, and we made a joke earlier, but me and Rachel walked B4 the other day because, you know, we had some people floated over there, and it was like a bomb had gone off on that unit, and not to down another unit, but I just don't want to be like another unit that you go over there and there's just trash everywhere, or like there's stuff all over the floors, and like it was just kind of hectic. It just felt hectic, right? And so sometimes here recently I've been walking around and I pick up a lot of trash, y'all, like all in the alcoves at the nurses station. Everyone's leaving all their like drinks that they didn't finish, and you know, it's like, let's pick up after ourselves. We are all adults here. um, this is not a daycare, you know, we're not here to babysit y'all, but like it's just a friendly reminder to pick up after ourselves. It's not my job to pick up after you either. And we want our unit to look pristine always. So please be mindful of that. And that goes the same for our patients' rooms. We do not need to be leaving a bunch of suction tubing all over the counters. We don't be leaving caps, torn alcohol swabs that we didn't throw away, you know, poo-poo in the trash. Like, let's take care of our patients' rooms and our things that it just matters. Okay, these little tiny things matters, and these things can be what take us from an 8 to a 9. Okay, because we got a lot of 8s right now. So just be mindful of that. Another thing to be mindful about here is quietness. There have been a lot of comments from phone calls after discharge, or that are on discharge comments, that patients are complaining about how loud it is at night. So night shift, sorry, but we got to keep the volume down, okay? Because our patients are losing sleep apparently. So please just be careful and mindful of how loud y'all might be being. Secretaries. So Nick, you know, he creates our mission and our stroke folders, and this was on our circle ups as well. Please make sure that we're not taking anything from those. Okay, if you need anything printed off, if our secretary is here, let them go ahead and do that for you all. But don't just take one sheet out of any of those. They're completed packets that need to be given to our patients whenever they arrive, and they shouldn't be missing any information. And so if you need something, we can print it off for you. Okay. Nursing excellence nominations are due 4/6. I put this on here because, you know, A5, we love to talk about each other and we love to hype each other up and say how awesome we are. But I do want to be, just let y'all know that this should be very thought out. And this should be a very, like a 2-paragraph kind of thing, whatever you guys want to nominate somebody for, whichever area that it might be. But you know, it's not that, oh, Tanner was awesome. He like always starts IVs for me, you know, and he's just a great charge nurse. Like it should be well, I don't know, described, or, you know, explained on how this person really truly affects the unit, patient care, preceptorship, however they might be, whatever you want to nominate them for, nurse of the year, and this is the why. It should be more than 3 sentences, 2 to 3 sentences. Okay. And then Kayla put something here in the chat. She says, for nursing excellence nominations, make it a good story. Those are the ones that who are chosen, and she's the one that helps choose the winners. So she knows from experience it should be more than just 2 sentences long. Okay. The only other thing I just want to talk about, I know this was lengthy and I'm so sorry, but NCC courtesy. So remember that I am an hourly employee just like you all. And so anything that is after hours, after 5 o'clock, maybe it can wait until the light of day, just because I do get a lot of messages from folks that maybe it can wait. You know that I love you all and I will respond just because that's who I am. But just be mindful that I'm hourly and anything after hours can and should go to Sowell. So, any questions about anything that I discussed? Thank you.
Wow.
All right, thank you, Crystal. Next up, don't forget license certifications. We had a lot of birthdays on there, so make sure you complete that birth month stuff. I'm also on that list. I'll be guilty. So I need to do my renewal too. We have 2 new residents starting that started 2 days ago. So you'll see them on the unit within the next 7 to 14 days out here, Fayaz and Kayla. As far as capital, so just over the past, I think 2 weeks or so, we had to reupholster 2 couches. Each one cost a little over 2 grand. We ordered the clamps for the suction canisters that go up on the wall where we can put them on the ring. We ordered 10, $2,200, and we had to buy a new Rover phone, $700. So it's a little over 7 grand just in a few weeks. And we get it. Things are going to break. We're going to buy stuff. That is fine. And so we're still within budget. And I know Crystal mentioned something earlier, and our unit clerks have done a really good job as far as bringing a concern about running low on these supplies or using the supplies quicker than what we actually need them for. Another unit, they did a project where they did something similar, and I think they saved like $1,000 for the whole fiscal year. And you think $1,000, it's not that much. An orange juice, give it away. That's 250, whatever it may be. But that stuff adds up. So at the end of the year, whenever you guys want a wish list, we're able to get those things. It makes it a whole lot easier. Okay. So continue being mindful of all the things instead of just throwing stuff, slamming things, being irresponsible with something. So we have to buy something new. It takes away from things that we can actually buy for our unit that will help us also. Patient experience. So we are right here, right down on the left-hand side in the red. We see our 2 biggest concerns in the yellow. As far as treating patients with courtesy and respect and help with toileting are the 2 biggest things that we are slacking in. As many of you probably went on Valentine's Day or sometime recently, a lot of you go to a restaurant and you expect good service, good food, a nice atmosphere. If you wait a long time for your food to come out, a long time to be seated, they mess up your order, your server is rude, the fries are cold, you're going to be upset. Anybody would, right? You may not come back to the same restaurant. You might say something to the staff of how rude the server was, or the waitress or the hostess was. Same thing here. We have patients that come in because they're sick, injured, and they're here to receive quality and effective care. And I know we have difficult patients. It's around the hospital on different units, and they can strike a nerve with whatever they say, whatever they do. We're all human. It happens, right? And so, for example, we had a patient on this floor. I know all you guys are familiar with. It was not quiet down one hallway the entire time, day and night, right? And it's stressful hearing that all the time, going in there, in and out. And so that frustration can sometimes lead to us going to a different room without us even intending it. Because they want something, they're complaining of it too, they're asking for something, and we're already annoyed with what's going on. So we may slam the door, we may give them a facial expression, scoff at what's happening. They don't know what's going on. and they see that and think, wow, this person was rude or there was a delay in something. And so we each have our own perception of what's going on. And Crystal and I would always advocate and listen if something happens. And we want to make sure that we are acting in a professional manner. And so make sure you don't let the emotions get the best of you. But also, we're not going to tolerate any kind of aggressive behavior, any kind of a lot of rudeness, whether from families or patients. So we want to make sure that you guys are aware of that, that we will advocate and listen to you guys. But make sure we get our feelings, don't get them involved or emotions involved because they may see something, a one-time thing, and think, wow, this was the worst service ever, but they don't know what's going on the whole unit. Crystal earlier made a really good point about the expectation of good hygiene care, cleaning our patients. So let's continue to make sure that we're communicating, working well together. As you know, this will help decrease the wait time that they're having to use a restroom, or addressing it sooner by doing hourly rounding, doing our 5 Ps, just basic stuff. We think it's basic and it's easy to do. A lot of it will help out. There's a unit on here that in one of those 2 domains, they were not doing so well at all. And so what they did is they focused on that stuff. And in those categories, by focusing on just receiving good daily hygiene care for their patients, even just saying a little, hey, thank you, or uh, not getting the emotions involved sometimes, they saw a huge increase. And now they've been green for some time now. So it can happen. We each have our things that we go through, our little ups and downs, and it's going to happen. So I know that we will continue to collaborate to work well together to make sure that, we increase those domains. And a lot of times we can be really fixated on just what are we doing wrong or what's not working well. But there's a lot of instances where you guys are doing a phenomenal job. Whenever we round with patients, Crystal and I, or we hear the feedback from our charge nurses rounding with these patients, and just the great things that they say about y'all. And not just in the kudos that we had in the first 2 slides, but just being very specific. I remember one elderly man down by room 17, a veteran, and he said, you know what? This is probably the best care I've received in a very long time. Your staff is amazing. I had a car dealership company. I would hire your staff days and nights because they're phenomenal. And so just with that, with families, saying that you guys are very patient, very diligent, and compassionate about what you guys do. So make sure we continue to do those same great things. So for our goals, where are we at right now? Our 3 goals: responsiveness, explain daily care, and patient experience. Responsiveness of staff currently at 57%. These are our minimum target and challenge. Explaining daily plan of care, 64.8%, really under that minimum mark. The currently percentile, the previous slide I showed you was 71, but from today it was 73rd. So we're right at the minimum. Okay. So again, there's little things that we do that make it go up, make it go down. And I think in last month's meeting, there were several 8s that we had. They were right at the cusp of being a 9 or being a 10. And an 8 and below, that will hurt us every single time. So we're right there where we need to be. Just a little more extra love. Any questions, concerns about anything with patient experience, like capital, or anything else that we may have missed? Nothing? Okay. If something does come up, maybe you don't feel comfortable asking on here, you can always reach out to us with any kind of concerns you may have. All right. So we're ending a few minutes early, and next up will be UBC. So if you're on UBC, make sure you stay on. Thank you everyone for attending, and we'll see you next month.